Hello, welcome everybody to part 1 out of 2 of the Gaps in Knowledge on the AKT-1. So a couple of months back, you all took the AKT-1, and we just got the results a couple of weeks ago. Subsequently, I put together a presentation of keywords that were most commonly missed on this exam. The AKT is not an ABA exam, but as you go through and take ABA exams in your residency, you'll find that these exams are broken down into keywords, which are small topics that you must know, that are ultimately taken and broken down from larger topics. In general, there are thousands of keywords that the ABA draws upon to write their questions. Each question generally requires you to know information based on several keywords, and so breaking your studying down in this keyword type manner is usually very helpful. So as we go through this presentation, I will pull different keywords out of the exam, we'll review them, and I hope you guys learn a little something. So just a little bit more about how this presentation works. So your academic preparation from here out until you take the basic exam in June of 2025 really should be geared toward that basic exam. It's one of the stepping stones that every CA1 has to get through, and the AKT is a good starting place. So please focus all of your attention now on this basic test. So the AKT is a little bit different, like I said. There are 9 total sections. They're broken into airway, anesthesia as number 2, whatever that happens to mean, 3 resuscitation, 4 physics and monitoring, 5 pharmacology, 6 physiology, 7 post-op, 8 pre-op, and 9 regional anesthesia. So as we go through, these keywords will loosely be based on one of those 9 subcategories. All right. So our first keyword topic here is airway innervation. What they want you to know about airway innervation is basically there are 3 main nerves that need to be blocked in case of awake intubation, and 4 if you are going to put the endotracheal tube through the nose. So the first 3 main nerves are the glossopharyngeal nerve, the superior laryngeal nerve, and the recurrent laryngeal nerve. Now, each of these nerves have both sensory and motor components. So the sensory innervation of the glossopharyngeal nerve is the posterior 1/3 of the tongue all the way down to the epiglottis, where the superior laryngeal nerve takes over. Now, the superior laryngeal nerve is broken into 2 portions, the external branch and the internal branch. Now, the internal branch is the sensory branch that takes sensation from the epiglottis all the way down to the glottic opening. The external branch of the superior laryngeal is the motor portion that innervates the cricothyroid muscle. The recurrent laryngeal nerve, from a sensory standpoint, takes over at the level of the glottis and innervates the upper trachea. And the motor innervation of the recurrent laryngeal nerve are all of the muscles of the larynx except the cricothyroid. If you are intubating through the nose, you also have to block the trigeminal nerve, and that comprises 2 branches, both the ophthalmic branch and the maxillary branch. The next keyword is choice of SGA, which means supraglottic airway, versus ETT, or endotracheal tube. I broke this keyword down into really benefits of both. So when you look at a supraglottic airway, it's generally easier to place than an endotracheal tube. On the emergence side, it's usually produces less coughing. Because it's a little more gentle, there's a reduced cardiovascular response when you put the LMA in. You can administer oxygen completely and continuously until your airway reflexes come back, and there tends to be a lower incidence of laryngospasm when you remove the device. Now, on the endotracheal tube side, you may want to consider using an endotracheal tube if you know that you have to use paralytic, because you can give positive pressure ventilation in a reliable way, whereas with an SGA, that's not always the case. When a patient has a full stomach, you tend to want to use an endotracheal tube because the supraglottic airway does not necessarily protect the airway completely if stomach contents were to come into the oropharynx. Endotracheal tubes should be used in non-supine positions, so either prone or lateral. When patients have reduced lung compliance, endotracheal tubes are usually a little bit better because you can give high pressures to ventilate, whereas with an SGA, that's not necessarily the case. Also, the last point, it's generally easier to place an endotracheal tube with limited mouth opening because there are other methods of placing an endotracheal tube rather than opening the mouth very wide. SGAs require patients to have reasonable mouth openings. Our next keyword here is head movement and endotracheal tube position. I think this is best remembered with a mnemonic. The hose follows the nose. So if you flex the neck down so the nose moves downward toward the chest, the tip of the endotracheal tube will advance, and in extreme circumstances, that can result in endobronchial migration of the endotracheal tube. In an opposite way, when the neck is extended up toward the ceiling, the tip of the endotracheal tube can be pulled back and migrate proximally, and in extreme circumstances, the patient can actually be extubated. So our next keyword is predictors of a difficult airway. This is a commonly tested topic that will certainly come up on the basic exam as you go on. This list that I produced here is from the Barish book, Clinical Anesthesiology, and they mention quite a few of them here, most of which we think about reasonably often, some not so much. I won't go through one by one all 10 here, but some of the more classic predictors of a difficult airway are number 8, thyromental distance being fewer than 3 finger breadths. The ability to or inability to protrude the jaw and bite the upper lip leads to a more challenging airway. Patients having a prominent overbite is one that's commonly tested. And then, of course, lack of normal range of motion in the head and neck leads to challenges. But just take a look at this list and sort of think about each one and how that may make airways more challenging. All right, so if you haven't caught on here quite yet, these keywords were taken from the airway section of the AKT. This is our final keyword in the airway section, rapid sequence induction. Here we have listed sort of the step-by-step process of a rapid sequence induction. The purpose is to gain control of the airway in as short an amount of time as possible after you remove all of the protective airway reflexes. So after administering cricoid pressure, which we have in the picture here, an IV anesthetic is given to induce sleep. A rapidly acting neuromuscular blocking agent, which is either Sux or high-dose rocuronium, is given immediately following. We're already holding cricoid pressure here for number 3, the Selleck maneuver, which is pressure downward on the cricoid cartilage. Ventilation is generally not done in rapid sequence induction, just because we don't want any chance that air will go into the stomach. After the patient is asleep and the neuromuscular blocking agent has acted, we secure the airway. And then the last point is extremely important. Cricoid pressure has to be maintained until we see end-tidal CO2 either on the monitor or confirmed in another way. That lets us know that the endotracheal tube is in the right spot, the balloon is inflated, and the risk of aspiration has passed. The first pharmacology keyword we have is dosing in morbid obesity. So the first thing to understand about this keyword is that you have to think about three scalars that are different ways to look at body weight. These are lean body weight, ideal body weight, and total body weight. Lean body weight represents the difference between total body weight and fat. Ideal body weight is the optimal weight for any person, and total body weight is what the scale reads when you look down on it. Now, different drugs are dosed in different ways based on these three scalars. Most of our agents are dosed on lean body weight. These include induction agent boluses and different narcotics. Paralytics tend to be dosed on ideal body weight. And the exception here is SUX, which is based on total body weight. And reversal agents are also based on total body weight as well, as are antibiotics. Our next keyword here is ensuring adequate denitrogenation. So why is this important? What does it mean? Before putting a patient to sleep, we will often have them breathe through a mask of 100% oxygen. The purpose of this is to clear the FRC of nitrogen and replacing it with oxygen. The point of this is that after apnea takes place, after our induction dose of medicines, the body has the ability to use this oxygen reserve measured by FRC while the patient isn't breathing. This will increase the amount of time that we have until desaturation occurs. And there are two well-described ways to ensure that the FRC is cleared of nitrogen as completely as possible. The first is to have the patient breathe 100% oxygen through a well-sealed mask, breathing tidal volumes for greater than or equal to 3 minutes. And the second way is to provide 100% oxygen through a well-sealed mask with 8 vital capacity breaths within a minute. And this will clear out as much nitrogen as possible and replace it with oxygen. So a keyword we may not think about very often is electrosurgical unit burns. So the electrosurgical unit is what we commonly refer to as the BOVI, although there are other types of ESUs as well. And they all place patients at risk for burns. So various risk factors for burns from these devices are use of monopolar cautery, or the BOVI or pencil cautery, and also improper placement of the grounding pad, which I'll talk about right now. So how does the ESU work? So the ESU refers to the box that usually sits on a cart right by the patient. The box generates an impulse. It travels through a line that terminates at the BOVI device. The electricity is then concentrated at the tip of that pencil and passes into the patient. Once the electricity goes into the patient, it's looking for a way to leave the patient. Most commonly, this is done through the grounding pad or the return pad. When this happens, the electricity moves to this pad. It's usually a wide surface, so it's spread out over a large surface of skin, and then the impulse returns to the electrosurgical unit. If the patient is contacted, in another way, the electricity is always looking for some point of exit. So this could either be the grounding pad, or if the body is touching a different conducting surface, the electricity may exit there. It could be a metal surface on the bed, it could be metal jewelry, it could be frayed wires, etc. But regardless, if the body is touching another conducting surface, some of that electricity may escape that direction and put the patient at risk for burns. Another way to avoid risk of burns is the use of bipolar cautery. One of the tips generates the impulse, and the other tip of the tweezer is the return area. And so there's very, very low risk of burn in that small space. So this keyword could comprise an entire lecture here. It is hypercapnea during laparoscopy. I will try to break this down as simply as possible, although there are so many different physiologic changes that can come from hypercapnea that this could probably encompass a whole hour or so. But as best I can understand, the key word is referencing that when a patient is insufflated with CO2 during laparoscopic surgery, this results in absorption through the various tissue surfaces and resulting hypercapnea. So when a patient becomes hypercapnic, there are many, many different systems-based changes that can occur. In the pulmonary system alone, you have, a lot of different, sort of sinister things that can happen. When the abdomen is insufflated, there is cephalad displacement of the diaphragm, which reduces lung excursion and can lead to atelectasis. There is increased PA pressure based on constriction of the PA directly due to the hypercapnia. The endotracheal tube can migrate distally and settle in an endobronchial location. The oxyhemoglobin dissociation curve can shift to the right based on the relative respiratory acidosis that you will see. Patients, if the surgeries go on for some time and there are high insufflation pressures in the abdomen, this can result in sub-Q emphysema, which basically allows for a reservoir of CO2 to be absorbed into the bloodstream over time. There are other cardiovascular effects, other neuroendocrine effects, other regional circulatory changes, and renal changes as well. I put a short list in image form over to the right. Like I said, we could go on and on and on about the various systems-based changes, but for this point in time, we'll leave it at that. I would encourage you to read other short blurbs as can be found on sites like Open Anesthesia and the various textbooks. Our next keyword here is composition of fluids. This is something that I like to go over in the operating room with medical students and the very newest residents in the honeymoon period. It's important to know that all fluids that we give are not created equal, and there are certain situations where some fluids are better than others. The key thing to think about when selecting a fluid is that our physiologic osmolarity falls somewhere between 286 to 290 milliosms per liter. And the chart that I've put over here shows the main components of a lot of the fluids and how that relates to physiologic osmolarity. So the top line here shows plasma with an osmolarity of about 290, and the chloride concentration is somewhere about 103, potassium is somewhere around 4, and then our natural buffer system is due to bicarbonate that's in the blood. Now, each of these fluids is a little bit different, and neither quite mimics plasma exactly. Our closest one is plasma-light. The osmolarity is very close to isotonic, and the concentrations of sodium, chloride, and potassium are very close to that of normal physiology. Now, you often hear folks say normal saline isn't normal. That's very true. There is the green isotonic check there, although in practice it's not actually isotonic. It's slightly hypertonic with an osmolarity of 308. This is based on the fact that there is 1 part sodium and 1 part chloride, both in concentrations of 154. Ringer's lactate is another that's somewhat close to normal physiology, but not quite. So this chart also gives it the green isotonic check, but if you look over, its osmolarity is 273, which is actually a little hypotonic. That comes from the fact that the sodium concentration is 130 and the chloride concentration is 109. There's also potassium, which is very close to that of a physiologic potassium level. The buffering system is also a little bit different. There's a lactate buffering system rather than the natural bicarbonate buffering system. So the next time you're in the operating room, pick up a couple of bags of fluid and go through them and look at the contents and think about how that might change normal physiology. Here we have Flumazenil indications. So first of all, what is Flumazenil? It is a GABA receptor antagonist, which makes it the reversal agent for benzodiazepines. Now, before we pull this out of our holster, it's important to eliminate other causes of unresponsiveness because these other causes tend to be worse than a patient who is too sleepy due to benzodiazepines. Now, there are a limited number of indications where Flumazenil use is appropriate, and we should always make sure that it is used only in benzodiazepine naive patients, mostly for accidental ingestion or perioperative oversedation. That one is more relevant in our line of work. Now, why is it important to give this only to benzodiazepine naive patients? So patients who are not naive to benzodiazepines are at high risk for seizures if given Flumazenil. Patients are also at risk for arrhythmias. Now, the dosing of Flumazenil, we generally begin with 0.2 milligrams IV, and we can repeat dosing if the patient does not become arousable up to a maximum dose of 3 milligrams. Now, it's also important to continue to monitor patients after we give Flumazenil because the half-life of this drug is shorter than that of most benzodiazepines, and patients can become re-sedated as Flumazenil wears off. Our next keyword here is perioperative anaphylaxis. So what is anaphylaxis? It's a feared complication during any anesthetic. In fact, we think about this so much in the pre-op assessment. We always ask about allergies, specifically to avoid this complication. This is an IgE-mediated response that leads to widespread mast cell degranulation and ultimate decompensation of the patient. Now, anaphylaxis is graded in four ways. Grade 1 is just cutaneous signs, meaning redness, swelling, wheals, things like that. Grade 2 anaphylactic reaction involves measurable but not life-threatening complications such as hypotension, tachycardia, some mild respiratory disturbances, as well as cutaneous manifestations in grade 1. Grade 3 is a life-threatening reaction. This is when the hypotension and respiratory disturbances become significant to the point where the patient's life is at risk. And then grade 4 ultimately is cardiovascular collapse, which in serious situations can certainly occur. Now, some agents that we use are more prone to anaphylactic reactions than others. These include antibiotics and neuromuscular blocking agents, which are the big two. I believe that folks tend to say that neuromuscular blocking agents are slightly more common than antibiotics, but these two are often interchangeable, 1 and 2. Other things that occur in the operating room commonly are chlorhexidine, certain dyes. Sugamidex has been known to cause anaphylactic reactions, and also one that's not written on this slide, but that we have to think about is latex and latex-containing products. So what type of treatment, if we recognize that an anaphylactic reaction is going on, what is our treatment algorithm? So the first thing that we have to do is that we have to stop administration of whatever we suspect is causing the allergy and to remove that allergen as best we can. The next best thing to do is call for help. This is always the right answer, both in real life and on the boards. We need to give these patients 100% oxygen and manage the airway if the airway is not yet secured. And then we move on to pharmacology. So since the mast cell degranulation leads to widespread vasodilation, we need to use volume expanders to fill this empty space. And epinephrine. Epinephrine is the best IV drug that we can use to directly treat the issues going on with an anaphylactic reaction. Other pharmacology that we can turn to but won't work quite as quickly as epinephrine are steroids and H2 blockers. And the last point under treatment, if it looks like this is heading toward a grade 3 or a grade 4 anaphylactic reaction, and if this is available to you at your institution, it's wise to notify the ECMO team so that they can come as quickly as possible should the patient deteriorate to that point. Post-op, there is a certain protocol that folks often use. It's wise to send these patients to an allergist to determine exactly what the provocating factor was, and a serum tryptase level can also be sent off. This is usually a send-out lab, and it can confirm that an anaphylactic reaction did actually take place. All right, here we have abnormal capnograph patterns. This one could also be a big, long lecture, but we'll try to simplify this as much as possible. So I included a picture of a normal capnograph on the top right, which has the 4 different parts of the waveform labeled, phases 1 through 4. And different pathologies and and non-pathologies can cause these capnographs to look different. So the most important part, I think, here, and I won't necessarily be able to go into grave detail in this setting, but I think the most important part is to understand what each part of the capnograph represents and how that changes in various pathologies. A couple that commonly come up, I've included over here on the left. So hyperventilation is a normal waveform with low end-tidal CO2. Bronchospasm shows a sharp upslope of phase 2 of the capnograph. Emphysema also is sort of an opposite sort of look. There's a bit of a downslope of phase 3. Cardiac oscillations are a normal part of physiology that represents the slight movement of CO2 in and out of the trachea with every heartbeat. And 2 others that appear frequently on tests I've included on the bottom right side. So this is when the expiratory valve of the machine gets jammed, as well as the inspiratory valve of the machine gets jammed. And they often ask you to differentiate between these 2 waveforms. So if the expiratory valve malfunctions, the end-tidal CO2 never quite reaches 0 because on exhalation, you have on inspiration, you are taking in air from both the expiratory limb as well as the inspiratory limb. Contrast that with when the inspiratory valve gets stuck. The end-tidal CO2 often does go down and reach 0, but there's an abnormally long sloped phase 0. Meaning that when inhalation is happening, you are inhaling CO2 that was breathed back out into that inspiratory limb. So if you're going to remember any two for the exams, take a look at those two, and please spend some time with these various waveforms. I have a really good reference on the bottom left from Life in the Fast Lane, as well as the chapter in Barish. Our next keyword is anesthesia circuit dead space. So this keyword also often comes up on tests and such. The answer here is that within the circuit, dead space is anything that is distal to the Y piece. The picture over on the right illustrates that nicely. Dead space is defined as any area that's ventilated but not perfused, and in particular ventilated with mixed air, both inspiratory and expiratory gases. So in the equipment, this would comprise the Y piece, the connector to the endotracheal tube, and the endotracheal tube itself, which is often forgotten. If we move into the body itself, anatomic dead space refers to parts of the body where ventilation occurs but perfusion does not. And this includes the trachea, the main stem bronchi, all the way down to the terminal bronchioles before we get to the areas of gas exchange. But in the anesthesia circuit itself, the pieces that are illustrated there on the right are what they're talking about. The Y piece, the connector to the endotracheal tube, and the endotracheal tube itself. Here we have attenuation of ultrasound waves. So ultrasound physics is a big topic. It's generally more widely tested on the advanced exam, but some simple concepts related to this can also appear on the basic exam. So attenuation describes how ultrasound waves lose energy as they pass through tissues and other objects. The higher the frequency of the waves, the more quickly the beam loses energy. What this means is that high frequency waves tend to penetrate less deeply and are better suited for imaging shallow structures rather than deep structures. Tissues affect ultrasound waves in a wide variety of ways, including reflection, refraction, absorption, and scattering, as is illustrated in the picture over on the right. And each of these will tend to affect attenuation of the ultrasound beam in different ways. Our next keyword is calculation of oxygen concentration from gas flows. This is a simple math question, but it is easily misdone if you forget that air actually contains 21% oxygen. I imagine that if you missed this question, that's probably why you missed it. But otherwise, it's a fairly simple calculation, and you can sort of figure it out using common sense. So oxygen, O2, is, of course, 100% oxygen. Medical air is just like the air that we breathe. It's 21% oxygen. So you need, based on the rate of flow, you need to calculate the total percentage of oxygen between these two gases. Now, if you're also mixing nitrous oxide in there, you have to understand that nitrous is 0% oxygen. It's pure nitrous oxide. And so you need to multiply the amount of oxygen in the air and O2 by 1 minus the nitrogen concentration. So for example, if you're running 60% nitrous, you would need to multiply the concentration of oxygen in both the O2 and the air by 0.4. So this is our second math-related keyword in a row, calculation of epinephrine concentration. If you haven't noticed thus far in your training in the first couple of months, math is an extremely important part of what we do on a daily basis. I've seen issues arise in the past where residents are off in their calculations by 1 decimal point or 1 zero, and that can result in some catastrophic medication dosing. And so it's important to recognize and check your math very carefully. So with epinephrine, it can be a little bit confusing at first, but luckily, as with most things, there's a standard way that it's described. And that standard nomenclature is listed down below as grams per milliliter. So for instance, if you pick up this box of epinephrine over on the right, which is in most of the Pyxis machines, you see that it says 1 to 10,000. What this means is that the concentration is 1 gram of epinephrine in 10,000 milliliters. Now, a code dose of epinephrine, if you remember, is 1 milligram per push. So when you go to codes on the floor, their ACLS is in progress, the nurses are pushing 1 milligram of epinephrine at a time. Now, this is 1/1000th of a gram. So you need to be very careful about the concentration that you grab and what you're giving. Now, the 1 to 10,000 box there, really what that means is there are 10,000 milligrams in 1,000 milligrams in 10,000 mLs, which means that 1 milligram is in 10 mLs. So often what you see in practice is opening up these boxes and pushing all 10 mLs for the 1 milligram dose that's required. Now, we use epinephrine sometimes in regional anesthesia as well for the purpose of having the blood vessels constrict in the area of injection to prolong the duration of the block. Generally, the concentration that we use of epinephrine in this setting is 1 to 200,000. It's much, much more dilute than what we have in the Pyxis machine. To break this down, it means that for every ml of solution, every milliliter of solution, we inject 5 micrograms into it, which if you're using concentrated epinephrine, either 1 to 1,000, which is in the vial, or 1 to 10,000, which is in this box, that is an awfully, awfully small volume. So it's important to check your math and to make sure that you're giving what you intend to give. Our next keyword is desflurane side effects. This is sort of a broad keyword. Without reading the question that was on the test, might be a little bit difficult to know what they were talking about, but it's often useful to break keywords like this down in a systems-based type way. Thinking about desflurane from a neuro standpoint, as with all volatile anesthetics, they dilate cerebral blood vessels, which ultimately leads to an increase in ICP. There's also a dose-dependent decrease in EEG activity. The patient goes to sleep, not surprisingly. From a cardiovascular standpoint, desflurane is a potent vasodilator, and unique to this inhalational anesthetic, there often can be a transient increase in both heart rate and blood pressure due to increase in sympathetic outflow. From a pulmonary standpoint, there is a decreased ventilatory response to CO2. This is important when we bring patients out to the PACU. If they still have a little bit of gas on board and their CO2 starts to climb, they're less likely to be stimulated to breathe. Desflurane in particular is very caustic to the airways. If you've ever smelled desflurane, you probably recoiled a little bit. It's not particularly pleasant to smell. Sevoflurane is a little bit more pleasant. From a musculoskeletal standpoint, it promotes skeletal muscle relaxation like other volatile agents, and it potentiates the activity of muscle relaxants as well. Environmentally, all halogenated agents are not great for the environment. They're potent greenhouse gases, but desflurane is particularly terrible. So I found an interesting fact here from the source listed below. They said that using desflurane for 1 hour at standard gas flows is equivalent to driving an average car about 650 kilometers. So not surprisingly, a lot of institutions, ours included, have removed a lot of the desflurane vaporizers from the operating room. It's also the most expensive of the halogenated agents, and so those two things combined have caused desflurane to fall out of favor with a lot of folks. All right, dexmedetomidine physiologic effects. So this is Precedex. It is a medication that we find in all of our Pyxis machines. It's not maybe something that you learned about quite a bit in med school or in internship, and so I understand why some of you may have missed questions about it, but we use it pretty often, so it's important to understand how it works and some of the effects. So from a pharmacologic standpoint, it's an alpha-2 agonist. It works on the central nervous system by inhibiting norepinephrine release. Again, breaking things down by system, from a cardiovascular standpoint, an initial bolus of dexmedetomidine will cause bradycardia and hypertension initially, and then ultimately a bit of hypotension if it's run via infusion. It is not necessarily a myocardial depressant. Contractility is well preserved. From a neurologic standpoint, patients are sedated but easily arousable even with higher doses. It's therefore a very, very useful sedative medication in the ICU setting for intubated patients. It does decrease the cerebral metabolic rate of oxygen, CMRO2, and cerebral blood flow. From a respiratory standpoint, it does not inhibit the drive to breathe and tends to allow airway reflexes to be preserved. In the liver, it's metabolized by the P450 system, and liver impairment can affect how the drug is eliminated, or metabolized rather, and the kidneys ultimately excrete the drug after it goes through glucuronidation in the liver. Often in renal impairment, it's not necessary to dose adjust because the metabolism takes place in the liver. Here we have naloxone dose. This keyword is probably a little bit different if you're an anesthesiologist versus a first responder or a police officer who carries a naloxone with them. We think about this from the standpoint of patients who have IV access. So naloxone can be given in a variety of routes, but we think about this as an IV medicine. So for a patient who out in the community is found down with respiratory depression, an initial dose is 0.4 milligrams to 2 milligrams, most likely IM or subcutaneous, but also IV if that's possible. It can also be given intranasally as well, which may be important for us, very important in the community, but may be important for us also if a patient does not have IV access. We tend to use this most commonly for postoperative opioid depression, and our dosing is much, much less than folks might use out in the world. So we generally can start with a lower dose, 0.1 to 0.2 milligrams initially. This can be repeated every 2 to 3 minutes as necessary, and ultimately titrating this to effect is the best thing to do. We do have to be a little cautious using this in the postoperative period because, of course, it inhibits the effects of narcotics, which can lead to significant pain if the patient has gone through a big surgery. Another big point with naloxone is that the half-life is shorter than most opioids that we use, and the effect of this drug may wear off in 15 to 45 minutes, and patients can become re-narcotized. So we can't forget to continue to monitor patients, and we sometimes have to begin infusions if a long-acting opioid is the culprit. All right, this may be one of the more important keywords that we've come across so far, the maximum dose of lidocaine, and then I added in and other locals because this will be something that you need to know for your entire career, not only for exams, but every time you use local anesthetics, this should be at the forefront of your mind. So with lidocaine, the maximum dose, if you don't add epinephrine to the solution, is 5 milligrams per kilogram. Now you have a little bit more leeway if you do add epinephrine, like we discussed Sometimes folks will add 1 to 200,000 epinephrine to solutions. This constricts blood vessels in the area where the local is injected, and so therefore there's less systemic absorption, and you get a little bit more ability to give a higher concentration. 7 milligrams per kilogram is key here. Bupivacaine tends to be a little bit more cardiotoxic and neurotoxic because of the long duration, and tends to be a little bit more dangerous. So the maximum dose without epinephrine is 2.5 milligrams per kilogram, and it doesn't change too much if you give epinephrine with that as well, 3 milligrams per kilogram. Mepivacaine is 7 milligrams per kilogram or 8, and ropivacaine, they say 3 milligrams per kilogram, although we often treat this the same as bupivacaine. Our last keyword for part 1 is opioid bioavailability. Now, different opioids will have different bioavailabilities based on a couple of different factors. So, and these factors they all fall under the umbrella of pharmacokinetics. So that's what the body does to the drug. Different factors include first pass metabolism, which means that some of the drug is metabolized into the liver before it gets to the site of action. The relative lipophilicity of the drug will affect how well it crosses lipid membranes and ultimately how quickly it acts. And also whether an opioid has active metabolites or inactive metabolites. The chart that's over on the right here shows sort of how some opioids are transformed into other opioids. So for instance, codeine doesn't act until it is metabolized into morphine, which is an active metabolite. Heroin, which obviously we don't use in the OR, and we hope that that's never an issue, but it, before it's active, is metabolized into one compound before morphine, and then ultimately is metabolized to morphine. Hydrocodone is metabolized to hydromorphone, and oxycodone is also metabolized as well. So based on the different drugs that you're using, they have different presence in the blood and ultimately act in different ways. Okay, thanks for watching part 1. It's never a bad idea to go back and read a little bit about some of the keywords that you feel you have shaky understanding of, and move on to part 2 when you feel good about things. Thank you for watching, and I will talk to you guys in a little bit.